Hello, my name is Lynn Lucas-Fehm. I'm the current president of the Pennsylvania Medical Society. I am very honored to welcome Dr. Jill Owens today to have a conversation with me on my initiative concerning various practice types. She'll speak to us a little bit about her personal experience and viewpoints. Let me tell you a little bit about Dr. Jill Owens. She's a graduate of the University of Pittsburgh School of Medicine, did her residency at St. Vincent Family Medicine, and is board certified by the American Board of Family Medicine with and a fellow in the American Academy of Family Physicians. She's been an active and thoughtful leader at both the state and national level for almost 30 years. She is a former president of the McKean County Medical Society and a Pennsylvania delegate to the American Medical Association. As an example of the esteem in which she is held, in April of 2020, Dr. Owens was awarded the PAMED Everyday Hero Award. The award is given to members who make extraordinary contributions through their daily actions. This group of physicians demonstrates commitment, compassion, and resilience as the cornerstones of exceptional care that contribute to community well-being. Dr. Owens' career commitments to her patients, community, and colleagues epitomize the Everyday Hero Award, and PAMED was honored to celebrate Dr. Owens. So thank you very much for joining me today.
No, it's my pleasure. Thank you for having me.
You have had such a varied experience, but the cornerstone of it has been your commitment to your patients. Can you just fill us in a little bit on what your experience has been and what your practice type that you have elected to do so well is?
Sure. So it has been a long time, as you mentioned earlier, and here almost 30 years. Wow. So I've actually, when I came out of residency, the trend was just shifting away from private practice. I'm a pretty entrepreneurial person, though, and still wanted to have my own practice. And at the time, hospitals really were trying to help us get started and launch us into our own practices. So I took that opportunity with a little rent to own practice and started my own 25 years ago in my hometown in Bradford, Pennsylvania. So it's been quite a ride and quite an experience, and I still maintain that practice myself. Although probably the last 3 to 5 years, COVID is really what pushed me into doing more administrative stuff at the time. But other than that, I've maintained the practice all the way through. And so I have another physician in there practicing now. But in 2020, I was helping our hospital system with a lot of the issues around the pandemic. And so took on a more of administrative role for them, as well as overseeing the practice operations and still practicing a little bit in there. And then that morphed into the CMO job. And pretty soon I found myself as the CEO of the two hospital system. And so it's been an interesting journey. And as part of that, I was helping to oversee the hospital owned practices. So not practicing among them because I still had my own private practice, but trying to help bring the private practice mentality to the employed physician practice of the hospital system that I was in. So it's been an interesting ride. And I will tell you now, I've finished that role. I concluded my time there last September. As the CEO of the health system. And it's good experience, I think, for me now to see that and then come back to where I'm at. I really do draw my personal pride and also my the rewarding aspect of practicing medicine from seeing patients on a day-to-day basis. And so that's where I am. Interesting though, because of my time away, I have a wonderful physician in my practice, young physician who's just getting started in her career. She's from the hometown of Bradford also, so she fit in perfectly. In fact, she's me 25 years ago, so it's great to have her there. And we have a midwife and a nurse practitioner also. So there really wasn't room for me to go back to full-time practice. So I'm actually in a town about 45 minutes away doing hospital medicine and then coming in and helping out at the practice and helping to oversee the nurse practitioner. So it's again been a great experience for me. And being back at the bedside, whether in the hospital or in my office, is really what drives me and rewards me to do the work that I do. So I'm super excited that I'm back in full-time capacity. So.
Wonderful. So would you say to some of our, especially our younger physicians, but really any age, because there's a lot of flux in where people and how people are practicing. There's movement going on at all stages of people's careers. So when we're looking at large health systems versus working for small health systems or a private practice, um, what would you tell them as some guidance as to why what you have elected for your practice model is something they should consider?
Yeah, so of course I'm going to tell you private practice is the best because it is. But I think, physicians tend to be entrepreneurial, right? And definitely, as I mentioned, I am. But I think, you don't go into medicine as a physician if you want to take orders and, just be another cog in the process of the health system. And I didn't find comfort there, even in the CEO role. We had a bigger health system over top of us. I did not find comfort in the role of doing what others felt best. And private practice really is the opportunity to do that. Now, it's scary. So I'm going to tell you, in 25 years, and that's why I advocate so hard. And I'm sure we'll talk about this later for physician payment reform. It's scary because, hospital owned practices, you have the guarantee that you'll have a salary, you have a contract. And so, you can practice without worrying about all that administrative stuff and the money coming in and doing the work to generate the revenue to pay the salary that you want to earn. However, to get that, you give up your autonomy and how you're practicing and how many patients you're seeing and what your practice type is. And, some hospitals and health systems are better than others at helping you to navigate that. But at the end of the day, it's a business to them. It's not, they're not in it for the patient, they're in it for the business and making the business run, which again, having done that role, I see both sides and they have to, they can't go out of business as many are. So that's something that's concern to them. But when you have your own practice, you really, you can set your schedule. You can see patients how you want to. You can make decisions on the fly. If you see an inefficiency, and one of the things that drives me personally is making sure things run efficiently and making sure that the patients get the good care that they need and all of that. And if you see something happening that's disrupting that, you're in charge. And so you can make the fix right there on the spot and turn things around. And, that's the kind of thing that drives me on a day-to-day basis to make healthcare better and make my patients access to care better and things like that. And so I wouldn't trade it. And again, I mentioned I'm not in there now. I'm actually doing a hospital's job, which ironically, I'm working for a physician-owned hospital group in that. But in this first time I've worked for another physician-owned group, I enjoy that as well. So if I was in a field and was going to do hospitalist only, that's, I would want physician-led. And I think, it's one of the other things that I'll take the time to mention it since it fits in this context is that I think physicians should be leading healthcare across the country, not just in their physician private practices or physician groups. I think they should be leading hospitals and health systems and I think even beyond that, maybe the insurance company and the payment system as well, because we know how healthcare is delivered. We know what the patients need. Most of us in medicine are not in it for the money. We're in it to make sure patients get what they need and are trying to find the most cost-effective ways to get things to the patients that need them, keep their access in check, and that kind of stuff. I think if you had more physicians leading the industry at all levels, I think we would be in much better shape than we are now. So kind of a long way around your answer, but it
Great
definitely
answer.
means a lot to me.
Yeah, so in terms of having to educate our people to become these leaders that we need, what do you think is the best way to go around to get people into these positions where they want to be the ones to work on or be at the lead of
Yeah.
health systems, insurance company, all these things we need physicians leader at? What should we do?
Yeah, so good question and a bad person to ask because I have no education in anything but medicine, biology and chemistry as an undergrad, but that was it. Yeah, I mean, I kept saying in my early career, next year I'll get my MBA, next year, next year, next year, next year. It's here we are 30 years later, and I don't have my MBA still, and I've been the CEO of a health system. So I think the bottom line is, I mean, again, most physicians have a pretty good business business sense and are entrepreneurial. So there's some innate desire to do that. I was fortunate. My family owned a business growing up. And so I had some experience watching them run the business. And that's probably my grandfather was a tried and true and tough businessman, tough as nails businessman. So I got to watch that in action. And I think that probably helped to shape who I am in that regard. But I think, learning little bit about the business side of medicine when you're in maybe undergrad, if you know you're going into medicine at that point, and then also in medical school is not a bad idea. If I had to do it over again, I probably would add in some kind of business training earlier in my career because, the first few years in private practice, again, I have no business experience whatsoever other than watching somebody do it. And, I had to figure out how to run payroll and how to, make ends meet and all of those kinds of things. And I relied on my hard work and successes in the practice to bring in the revenue to do it. And I was very fortunate and still very fortunate that I have a successful practice, even in times where the payment has gotten tougher and tougher. And that, hopefully as the payment system shifts, which I'm still counting on the fact that it will at some point, I think, having that business knowledge as a physician, to be able to partner it with your clinical knowledge and execute the business of medicine, I think is really where a lot of us need to be.
So you've mentioned a little bit about how the payment system and all the administrative aspects that go along with that are hopefully going to change. What would you recommend as the best way to help that change occur? I mean, you and I both know about the power of speaking with legislators, speaking with all that, but maybe you can extend a little bit so perhaps we can instill that need to more of our membership to get involved because there is power in numbers but there's also power in one person even speaking. I've had more than one legislator tell me they don't see their physician, that they don't come to them as constituents. So what can you advise so that we can make that difference to maybe bring about the changes we need?
Great question. And PAMED is a great resource to do that. So advocacy is the key. And I will tell you, my story into advocacy has not been one. I didn't go into advocacy wanting to be an advocate for myself, my patients, or any, my business or any of it. I went in because Dr. Anita Herbert, who was an occupational health doc here, was active in the Pennsylvania Medical Society, going to the meetings. And I somehow found myself drawing this short straw and being the president of our McKean County Medical Society one year. And she's like, you got to come to Hershey to the meeting with me. And I don't want to go. And, I dragged my feet a little bit. My kids were little and she's like, bring your kids, have a good time. So I did. I brought my kids, the whole family. We came down to Hershey, had a fantastic, fun weekend, met some young physicians with similar challenges in private practice like me. And, just immediately, found a friend group that I knew I could count on and talk to, and still many of them friends today. Which has been really cool. And then as part of that, my first young physician meeting, well, we need a delegate to go to the AMA. And again, I don't know, I don't have time. And the meeting happened to be in Hawaii, which was a nice little, okay, maybe I can make time for that one. And again, you get in there and you see the issues that you're advocating for. And then all of a sudden, it gets real. What are physicians struggling with? And right now, the biggest thing we're struggling with is they don't pay enough to the physicians and the healthcare team to be able to execute the job that they're doing, and especially in private practice, although it hits the employed physicians too, because again, having run two hospital system with lots of employed docs, they're not getting paid enough, which means the physicians have less of a role and less of a value, so to speak, in the system because they're not, their income is not generating the biggest end of the hospital revenue anymore. So all of a sudden, we are not a valuable member of the team, which is just incredible. We are the ones providing the care and doing all of the clinical work. We should be the most valuable member of the team. And so I think, and that's where the payment system is just totally screwed up. And I will tell you, I wish I had the answer to this, but I don't, but I think, they need to start putting the payment to the work that's being done to take care of the patients and give the patients more autonomy and say in the decision making, and give the physicians and the rest of the healthcare team more of a say in how those dollars are being spent, rather than these bloated administrative juggernauts of, big health systems and things, and bigger is better. Bigger is not better. We've now demonstrated the outcomes are worse, and the care that people are getting are worse. People are so removed from the patient they don't even realize they're working in healthcare sometimes, and that's just a shame. And I think if they changed the payment system and focused it where it needed to be, it would be a lot better. And so again, now I find myself in this advocacy role, and it's so easy to get passionate about it. And even as a health system CEO, I had great relationships, thankful, for PAMED to providing me the advocacy start. I already knew my local legislators very well personally, and I knew a lot of the guys in Harrisburg. I knew people in Washington, and had those connections and inroads. And you're absolutely right. We need to be knocking on their door and talking about this stuff. We need to talk about the issues that are important to not just us as physicians, but our patients. Again, we're there at the bedside talking to them. We know what they can afford. We know what they can't. We know their access issues. We know now that a lot of them in rural areas are driving hours to get, to see a gynecologist and deliver their baby, or even see their primary care doctor. I mean, I have patients when I was actively practicing day to day that were driving over an hour to see me. So, that kind of stuff, you really, there needs to be a shakeup in the system, and the payment has to change to get the money where it's needed, instead of these corporate giants that are, blowing the money on, again, layers and layers of administrative overhead that's not really helping where it's needed, which is at the bedside with the patient, or in the office chair with the patient. So, and again, there's only one way to change that, and that is to go to Washington, or go to your, Harrisburg, or wherever you're at, wherever your legislators are at. And I think making the relationships with them, the personal relationships, so that they understand, and you can have a conversation with them, and not, you're not just going there to pitch whatever issue is at the top of your list for the day. They really understand the challenges you're facing, and that's been the key to the advocacy. And I will tell you, it's the thing that I never thought I would like, and I absolutely love it. um, for me, it's even with the patients, it's about the relationships. With my legislators, it's about the relationships. So it's been kind of a cool experience for me. And we're not done. We've got some positives here this week with some of the things that are coming through Washington, but that's, really that's the tip of the iceberg. And there's so much more that we need, inflationary updates, which I think they gave us a partial update, not a full update. So hopefully at some point we can see something that actually has meaning and can restore the private practice model. And I think that will save medicine, actually.
So one thing you've mentioned several times, and I know you work in a rural area.
Very, yeah.
Oh, rural America. I mean, look, all of medicine needs a lot of attention and the way this, but I think in particular, there are areas in rural America. I think there's one area in Pennsylvania where a woman might have to drive 2 hours to see an OB. There's this huge, they call them healthcare deserts sometimes. What in particular can help drive more physicians, more ability to take care of our rural communities?
Yeah, so I think that OB Desert that you're referencing is up here. So northwestern Pennsylvania, we've had a few health systems pull their OB out of hospitals. My hospital in Bradford was one. They closed OB in 2018, I believe. And the local hospital here, maybe 40 minutes down the road, just is their big system is also closed theirs recently, I think April 1st. So there's women now driving huge distances to deliver a baby. There are some, providers in the community, so to speak, but they can't deliver the baby in the provider office. You have to get to a hospital that's equipped to do that. And so it's created a ton of problems. And again, that's just OB. OB is the worst example because that's the thing that's in the highest need, but specialty care and primary care deserts are here as well. And so patients oftentimes are just commuting a huge distance to get there. And a lot of them, the poor, especially the ones that we're trying to reach, don't have access to reliable transportation. We don't have good public transportation system here. We do, but it's limited. We don't have the same kind of system that you'd have in a city. So, those kinds of things really impact access. And again, if I had the solution, boy, I don't know if I'd be doing the jobs I'm doing. I would be doing something much, much bigger. But I think, at least the way I see it, regionalization of care is the answer to that. And the problem is the health systems all compete. And so there's no regionalization. Like up here, we have 3 health systems fighting for the same population. And unfortunately, those health systems are not fighting for the poor. right? Because the poor, Medicare, Medicaid, those insurances don't pay well, as we talked about. And so, they're not fighting for those patients. They're fighting for the high end, commercial insurance that pays better in the big procedures, the joint replacements and the heart surgeries and all of that kind of stuff. And forget about the fact that there's patients in these places that need basic services. And so, what I think they ought to do, and I had the good fortune to serve for a short time when I was in my CEO role on governor's task force here in Pennsylvania. And what we talked about, I don't know where it is because I ended my time on the council as well. But I think they need to start figuring out what the areas need, and then stop the competition and force them to put resources there. So if you're one of the insurers that has patients in that area, you have to help provide access to that hospital or health system in that region that's necessary to provide, whether it's OB or primary care or whatever the need is. And again, not every place can have everything, but you have to have at least geographically located health systems that can provide it, so that patients, because we see the morbidity and mortality climbing, especially in OB, and that's the reason why. That's a big reason why is people don't have access to deliver. And the downstream effect of that is the businesses are going to suffer too, because if I was a young woman right now, I mean, even in medicine, but if I'm working in a factory or I'm working as an executive in a business here, why would I choose to come here if I can't deliver my kids in the hospital close to where I live, and I have to drive an hour and a half, 2 hours to do that? That's crazy, because if I have a complication, now I can't work until I deliver my child. I've got to move somewhere and find, and if I'm poor, I can't do that. So, it has a downstream effect that's going to be catastrophic to the communities up here. And this is happening all across, not just Pennsylvania, but all across the country. And I think if we don't get serious and get politics and all this other nonsense out of medicine and start doing what's right, we're going to have get worse before it gets better, so to speak. And so I'll continue to advocate for that as long as I have the breath to do it. So.
Wonderful. Um, at the same time, the rural areas are affected. In the case you were talking about, you had the larger health systems actually pulling out and pulling the care away. The other thing that also has a tendency to create some of these healthcare deserts is private equity. And I understand there is some influx of that coming into rural areas. And of course, we also know already, like, for example, in a more urban area, that what happened with Crozier, and that has created an urban healthcare desert in a sense. So, what do you have some take on that and how it's influencing everything?
Oh, sure. So, you got to follow the money. And when there's somebody else that's financially responsible and in charge, you're always going to have, to answer to that entity, whether it's a big health system, a corporate entity, the government, or private equity. Now, the difference with private equity is you can have physician, owned or led areas in there as well. So maybe your investors or whatever are not necessarily some outsider that doesn't care. But the problem is, so you have to be very careful then of who you're choosing as your partners. And once you give control to somebody, whether it's a health system or a private equity firm, they may give you this nice talk and song and dance about how they care, and they care about your community, they care about you, they care about your practice, whatever the case may be. It all sounds good. And believe me, I've had people trying to sell it to me. I think over the years, my practice has been courted by every health system in the region and a few private equity. But once you sell, you've given the keys away, and then you're going to have to ride in the car and not drive it.
Yeah,
That's a
sure.
trade-off that I'm not willing to make at this point in my career. And actually, now that I'm getting older, I'm less likely to let somebody else drive. So anyway, I probably won't ever do it. But again, I think there's some promise, the fact that other people can be part of that, and maybe that leads to where I think practices should go, which is physician-owned groups. So let the equity come from groups of doctors. And that way, at least you have trustworthy partners who are in the game with you and know the business and know the clinical side and know what it takes to practice. Because again, the less educated in clinical medicine the person is above you, the less likely they're going to be able to help you execute that business. Medicine is unique because it's not like making widgets. You can't have just any person who's gifted in finance or gifted in whatever business acumen they have come in and start to dictate how to do it. That plays a little. I mean, you have to have productivity, obviously, or you're not going to be able to pay the rent. But you do have to have a balance between caring about the patients and making sure that the resources are there for them, and also the physician's well-being, as far as you can't have them seeing 30-35 patients a day like we did early in my career. You've got to have some balance, so you're making sure that they're making good decisions and they have the time to provide the care that the patient needs. So again, not a big fan of that either, but I think it's, of the three, it's probably the least offensive to me.
All right. Is there anything that in particular you think our membership should know? Or just I want to give you a few minutes just to speak your mind here
Sure.
and educate us, please.
Yeah, I think what a great resource. So PAMED, again, I kind of stumbled into it. Wasn't really that interested in doing it. And now I can't get away from it. But what a great resource, right? So again, it's helped shape my advocacy across my career. Make connections that I never would have made. Great physician friends of mine from all across the state and now with the AMA all across the nation, that are passionate about it like me. And there's something to be said for that. Part of the reason I think I've never burned out, because I've worked really hard over the last 25 years, and there's been, jobs that I've had where, burnt the candle at both ends and then some, and then trying to navigate my kids' hockey schedules and everything on top of that. It's a challenge. But I think, having physician friends who do the same thing and have the same challenges and being able to network and talk with them and sometimes just unload and cry on their shoulder kind of thing, it makes a huge difference. And sometimes you just get that either pushback, hey, it's not so bad, or, hey, I tried this in my practice and it worked great. And, I can't even count the times that I've had, people help me out navigating things. And like I said, when I was in the CEO job, I called on a lot of my connections through PA Med, whether it be doctors. I had a physician who's a good friend of mine through all my PA Med and AMA work, who helped provide locum coverage when we needed it in our ICU. And I used the advocacy with the politicians, and those connections. And so for me, throughout my career, it's had benefit after benefit after benefit. Basically think the biggest thing is getting the resources from PA Med. And a lot of docs get on that hamster wheel of just providing care to patients, and they sometimes don't see the bigger picture. And I think taking time out to do these things, not only beneficial for yourself, and your state of mind and your resiliency and stuff, but also giving you the resources that you need to do your job, and advocate for what we need in medicine. So many good things that I can't say enough about PA Med and the help that they've been to me over the last 25 years.
I agree. And perhaps one of the best things that I've heard you say throughout that I think is so key is physician autonomy. I feel it's better for the patient. I mean, it sounds as if physician autonomy, it's about the physician, but in so many ways, I think it's really about the patient. You can't do the best job for your patient if you have no control over your own profession. So,
I
um,
agree.
yeah.
Yeah, I couldn't agree more. I think, being able, we know as doctors what patients need, and we oftentimes know how to deliver it, and, the best environment and resources to do that, and also the best evidence-based medicine. We're taught in medical school things that other members of the healthcare team are not. And so we have a unique ability to reach patients and get them what they need. And there's a lot of, noise out there now on both sides of the aisle with different things coming at us. And at the end of the day, we're the ones that can help sort out the evidence and the needs of our community and our patients, and get the care that's needed to where it's needed. And I think, trust is a big thing right now, and it's hard to know who to trust because you've got so many different voices and, again, so many different things. I'm not going to go down that rabbit hole, but I do think that patients are looking to their doctors as someone that they trust and that they know that they can count on to give them what's necessary and what's needed, and what the evidence supports using for them in cases like that. And I think that's going to go a long way. And again, having those resources with different agencies like PAMED is key to getting it. So.